So good evening. My name is Isabel Prieto. I am a urogynecologist for AdventHealth Tampa. I just recently joined the team about 6 months ago, so I'm excited to be here. I am going to go ahead and start my part of the talk. This is going to be an overview of urinary and fecal incontinence updates with Dr. Massarotti and I. I'm specifically going to concentrate on discussing urgency urinary incontinence and overactive bladder, as well as the current treatment options. I have no relevant financial disclosures. My objectives tonight are to briefly discuss bladder physiology as a quick review, define what is urgency urinary incontinence as well as overactive bladder, discuss the clinical considerations when treating these patients, as well as discuss the bladder care pathway and discuss treatment options for these diagnoses. So just as a quick review of the physiology of the bladder, we have three major innervation pathways, the parasympathetic pathway, the sympathetic, and the somatic. When we think about filling and storage phase, we have to remember that our pelvic nerve, which is part of the parasympathetic system, is inhibited during filling, and the sympathetic nervous system is actually stimulated, causing beta relaxation of the detrusor muscle and alpha contraction of the bladder and urethra. The somatic nervous system also is stimulated, and it activates the striated urogenital sphincter, the perineal muscles, and the external anal sphincter to maintain continence. And then the voiding phase is essentially the opposite, right? So we have the parasympathetic nerves that are stimulated, and muscarinic activation causes contraction of the detrusor muscle. Sympathetic nerves are inhibited, which also causes beta contraction of the detrusor muscle and alpha relaxation of the urethra. And then the somatic nerves are inhibited, specifically the pudendal nerve, and that in turn leads to relaxation of the urethra and the pelvic floor. It's important to define certain terms that we use when it comes to urgency urinary incontinence and overactive bladder. Specifically, urgency refers to a sudden compelling desire to pass urine, which is difficult to defer. And urinary frequency was traditionally defined as greater than 7 episodes of micturition during the day. However, we now know that it's multifactorial and it can vary greatly. Nocturia is generally the complaint of interruption of sleep, one or more times because of the need to void. And urinary urgency, frequency, and nocturia create a conglomeration of symptoms that we define as lower urinary tract symptoms. Overactive bladder specifically was defined by the ICS, and it's considered urgency with or without incontinence, usually with frequency and nocturia in the absence of pathologic or metabolic factors that would explain these symptoms. The prevalence is something that I wanted to focus on quickly because it is much more prevalent than we actually think, and patients are really surprised to hear how common it is. Approximately 37 million US adults suffer from overactive bladder, and that's about 1 in 6 Americans. In population-based studies, overactive bladder prevalence rates range from anywhere from 7 to 27% in men and about 9 to 43% in women. As you can see here, it increases with age, and it is generally more common in women than in men. And the total US economic burden of overactive bladder is about $12.6 billion. When we talk about overactive bladder, we generally talk about 2 different categories, that of non-neurogenic overactive bladder and neurogenic overactive bladder. For the scope of this talk, we're going to concentrate just on the non-neurogenic, and as you can see, there's several causes. I highlighted obstructive sleep apnea in this list, specifically because that's an updated topic that is of interest now. This month, an article was actually published in the Journal of Neurourology and Urodynamics, highlighting the effect of continuous positive airway pressure on nocturia in patients with obstructive sleep apnea. And it was a prospective study of about 274 patients, and they determined that the prevalence of nocturia was around 75% in both genders. And CPAP significantly reduced nocturia with one or more episodes per night in 42.3% of these patients. So what they considered clinically relevant nocturia, or greater than 2 voids per night, was reduced from 73% to 51%, and there was no change in gender. And I think this is really important because I have been seeing many more patients now, and it's definitely a counseling point on these patients when we talk about conservative measures that we can take to manage non-neurogenic overactive bladder. There are several clinical considerations. However, in most cases of overactive bladder, we can diagnose it based on a simple history and physical, their symptom assessment, as well as urinalysis. And it doesn't generally require extensive workup. However, if you do suspect other complicating factors or that the patient's symptoms don't quite fit the bill for overactive bladder, it's important to consider further evaluation with things such as urine cultures to rule out cystitis, post-void residuals, especially when concerned about urinary retention or overflow incontinence per se, bladder diaries that can better define the patient's symptoms, as well as symptom questionnaires. And I just posted here the AUA guidelines for non-neurogenic overactive bladder in adults, which is a nice guide to explain how to evaluate a patient. This is our bladder care pathway, and this essentially is something that I have in every room when I walk the patients through the treatment options. Specifically today, obviously, we're concentrating on overactive bladder, but it walks the patients through the conservative treatment options down to the surgical treatment options. So it's a nice visual for them. Let's talk a little bit about first-line therapy. So conservative measures include dietary and lifestyle modifications, bladder training, and pelvic floor physical therapy. And I don't think that we truly give them enough credit. When we talk about dietary and lifestyle modifications, questions as simple as what are you drinking every day can reveal a lot. I've had patients tell me they drink 12 cups of black tea in a day, so I've quickly identified the problem. Smoking cessation is something that I definitely counsel these patients on, as well as weight loss. One of the more important studies showing the effects of weight loss was a definitive trial that reported a 6-month behavioral weight loss intervention that resulted in about an 8% weight loss in obese women, and it actually reduced the overall incontinence episodes per week by 47%, compared to 28% in the control group. And it reduced their actual urinary urgency incontinence episodes by 42% as well. So that's a pretty big change. Behavioral therapies in general were selected as first-line therapies because they present essentially no risk to the patients, but they do require a buy-in from the patients. One of the approaches focuses on modifying bladder function by changing voiding habits, such as bladder training and delayed voiding. Other approaches focus on behavioral training, on essentially the bladder outlet and pelvic floor muscle training to improve the strength and control techniques for the urge suppression. Specific components of behavioral treatments can include self-monitoring, bladder diaries, scheduled voiding and delayed voiding, double voiding, and then the pelvic muscle therapy. Although most patients don't generally experience complete symptom relief with behavioral intervention, the literature does indicate that most patients experience significant reductions in symptoms and improvements in quality of life. And it's been shown that behavioral therapies can result in symptomatic improvements similar to antimuscarinics without exposing these patients to adverse events that we'll talk about. So this is a list of what we consider second-line therapies, which are medications. We have 2 categories: the antimuscarinic medications that I'm sure you're familiar with, as well as the beta-3 adrenoreceptor agonists. Until shortly, we only had myrbetriq on the market, but we now have a new medication called vibegron, and I'll go into some more details on that. So essentially, these medications do block the muscarinic receptors in the detrusor muscle based on different selectivities. In general, they all have similar side effect profiles, and we will go into that a little bit deeper. All 5 receptors do cross the blood-brain barrier, although there are some that are thought to less readily cross the blood-brain barrier, such as trospium, and that'll come into play when we talk about the adverse side effects of these medications. There is some literature that indicates that initiating behavioral and drug therapy simultaneously may improve outcomes, including frequency, voided volume, incontinence, and symptom distress. And so we often use medications concomitantly with first-line therapies. An extensive review of the randomized controlled trials that evaluated the pharmacological therapies for overactive bladder, including trials with placebo-controlled groups, as well as trials with active treatment comparison groups, revealed no compelling evidence for differential efficacy across medications. And the AUA actually performed a qualitative analysis of overactive bladder medications trials, which that for 24-hour frequency, urgency, incontinence, baseline symptom levels were closely related to the degree of symptom reduction across medications, regardless of the inclusion criteria of the study or the dosing regimens. For urgency and nocturia, however, there was no apparent relationship between baseline symptom levels and symptom reduction. It is important to touch base on the side effects of these anti-mascaronic medications. They are contraindicated in patients with uncontrolled tachyarrhythmias, myasthenia gravis, gastric retention, and narrow angle closure glaucoma, as well as supraventricular tachycardia. All of the muscarinics exert peripheral anticholinergic effects to a certain degree, and they all have additive side effects with other medications that have strong anticholinergic effects. And this is quite important as we talk about the next hot topic in the research on antimuscarinics. So there is a lot of focus now on antimuscarinic use and the risk of dementia. Two of the stronger studies showed a nested control study essentially that showed about 58,000 patients with dementia, and 225,000 of those controls, the exposure to antimuscarinic bladder agents over the prior 1 to 11 years was associated with an increased risk of dementia. In the 2015 population-based study of 3,400 participants examined association between cumulative anticholinergic use and risk of dementia. It was interesting that the bladder antimuscarinics accounted for about 10.5% of the medication use. However, antidepressants did comprise about 63.1%, and antihistamines comprised 17.2%. And the highest exposure category, which were patients taking 5 milligrams of oxybutynin daily for greater than 3 years, had significantly increased risk of dementia compared with no use. Obviously, this doesn't show causation, but the American Urogynecologic Society's Choose Wisely campaign has now recommended the avoidance of anticholinergic medications to treat overactive bladder in women older than 70 years old. Mirabegron was developed as an alternative to antimuscarinics. When we look at the efficacy trials, NITI in 2013 reported findings of pre-specified pooled efficacy and safety analysis using the data from multiple of the phase 3 trials. A few important points that we found was that mirabegron 50 and 100 milligrams once daily in comparison to placebo significantly reduced incontinence episodes per day and voids per day at 12 weeks. There were significant improvements in the mean voided volume, the mean level of urgency, the mean number of urgency episodes, and the mean number of urinary urgency episodes per day, and mean number of nocturia episodes per day were also noted for both doses compared to placebo. And the proportion of patients reporting 0 incontinence episodes was significantly higher in the mirabegron group compared to placebo. They did know that the efficacy in patients who had previously used antimuscarinics compared to treatment-naive patients was similar across the doses. And it is important to note that the 25 milligram dose significantly reduced the frequency and incontinence episodes, but not generally the other endpoints. The 50 and 100 milligram doses also significantly improved ratings on the treatment satisfaction and VAS compared to placebo. And there was no dose response gradient for the 50 milligram dose compared to the 100 milligram dose, with both doses producing similar effects. The National Institute of Health and Care Excellence in 2013 essentially evaluated the evidence behind mirabegron as well in preparation for release to the UK providers, and they performed a mixed treatment comparison analysis that compared and combined data across trials and treatments that were never tested head-to-head. So the NICE concluded that all medications, including mirabegron, had similar efficacy to reduce frequency. With regard to incontinence episodes, mirabegron and other medications also were similar in the exception of solifenacin, the 5 and 10 milligram doses, which significantly was more effective. However, the size difference was quite small. Taking a quick look at the mirabegron side effects, data from the phase 3 trials was pooled in 2013, showing rates of adverse events were similar across the groups with the exception of dry mouth, which was higher actually in the tolterodine group. Changes in the pulse rate and blood pressure were minor and similar across the groups, and the rates of tachycardia were less than 5% in each group, which were comparable to placebo. Another study in 2013 by Chappell et al. Also reported adverse events during the 12-month period compared to tolterodine. The rates of the adverse events were generally similar across the groups as well, with the exception of dry mouth, which was higher in the tolterodine group. And blood pressure changes were quite minimal, less than 1 millimeter of mercury, as were the pulse rates changes, which was less than 2 beats per minute. So the AUA recommends that mirabegron be avoided in patients with uncontrolled hypertension, systolics greater than 180 and diastolics greater than 110. And in patients who have less severe hypertension, it needs to be closely monitored. In those patients who are essentially unable to increase antimuscarinic dosing due to side effects or dose limits, then we can consider combination therapy. There's 2 well-known trials, the Synergy and the Beside trial, which compared mirabegron in 2 different doses to solifenacin in 2 different doses, compared to solifenacin alone. Essentially, the combination therapy resulted in improved overactive bladder symptoms compared to monotherapy use. However, in these patients, we do have to closely monitor for urinary retention. And one of my favorite topics is estrogen therapy. There's a lot of data now on estrogen therapy and urinary symptoms. In 2016, Ellington et al. Performed a randomized controlled trial evaluating combination of tolterodine and intravaginal estradiol in 58 menopausal women. And they randomized these patients to either oral tolterodine or estradiol cream for 12 weeks, and then offered addition of alternative therapy with 24 and 52-week follow-up. And what they found was that both monotherapies resulted in decreased symptom bother scores at 12 weeks. The overactive bladder symptom severity and the health-related questionnaire scores remained improved significantly at 24 and 52 weeks following addition of alternate therapy. And only the addition of the tolterodine at 12 weeks to the estradiol group actually resulted in further significant improvement in the OAB group bother scores and the health-related questionnaire scores above the single therapy noted at 12 weeks. So the bottom line is, if we have menopausal patients, we should always consider the effects of atrophy on the urethra and the bladder as well as the vagina, and estrogen, even estrogen alone, can improve these symptoms. So a quick note about the new medication that is actually just been FDA approved and will now be out on the market starting in April. Gemtesa, their claim to fame is that it essentially has greater beta-3 selection and less beta-1 selection in the heart. And there's no effect on the CYP450. It's crushable and can be mixed in soft foods. And they actually performed a 4-week ambulatory blood pressure study on overactive bladder patients. The mean age was about 59, and 75% of these patients were female. 35% of the subjects had pre-existing hypertension at baseline, and 29% were taking at least 1 antihypertensive. And the rates of hypertension were somewhere around 1.8%. So what is the truth about compliance? This is probably the most common question I get from patients is, am I really going to be on this medication for the rest of my life? And the bottom line is no. A systematic review of 72 randomized trials found that rates of medication discontinuation due to adverse side effects ranged anywhere from 1% to 6%. In clinical trials in women with incontinence, discontinuation of all antimuscarinics due to adverse effects was higher than placebo, and dry mouth was generally the most common reason for discontinuation. When we look at the data, less than 50% of patients actually continue medications beyond 6 months, and less than 36% continue beyond 1 year. Mirabegron specifically, because obviously it's in a different category as a beta-3 receptor agonist, the discontinuation rates are a little bit better. So in a retrospective study of 21,000 male and female patients, the time to discontinuation was about 169 days for mirabegron compared to 30 to 78 days for antimuscarinics. So that brings me to our third-line therapies. Our first third-line therapy is percutaneous tibial neuromodulation. I consider this essentially the least invasive of the options. It was initially discovered as part of a transcutaneous patch tibial nerve stimulation by McGuire in 1983. And it was investigated as the tibial nerve is essentially a terminal projection of S3. It involves placing a 34-gauge needle 3 to 4 centimeters above the medial malleolus and increasing the amplitude of stimulation. It does require about 12 weekly sessions for 30 minutes each, and the responses generally occur within 5 to 6 sessions, and improvement occurs after 12 sessions. At that time, then you continue to monthly treatments for a year. It does have low rates of side effects, essentially just pain at the stimulation site. And as you can see here in 2017, a prospective study of 200 women with overactive bladder maintained efficacy was reported at 30 months for daytime urinary frequency and 18 months for nighttime frequency. Botulinum toxin A was FDA approved in 2013 for non-neurogenic urinary binds essentially to the nerve terminal. The light chain blocks the fusion of the neurotransmitter vesicle with the nerve membrane by cleaving SNAP25 and decreasing the muscle contractility. Botox is an option in the office or in the operating room. It requires repeat injections anywhere from 4 to 10 months. And in the literature, the median injection time is about 7.6 months. There are risks, small risks with Botox. Generally, about 6.5% of patients will develop some type of transient urinary retention, which peaks essentially around 7 to 14 days and generally resolves within 9 to 12 weeks. Rates of urinary tract infections within the first year can vary anywhere from 21 to 35%, and these measures have been shown to be higher in diabetic patients, up to an 11% retention rate. A small amount of patients undergoing repeat treatments may also develop antibody-mediated resistance to the clostridial proteins, so it's important to keep that in mind because it could render it less effective with subsequent treatments. And by a study by Brubaker et al., in the New England Journal of Medicine in 2012, they compared oral medications to Botox, and what they found was that there were similar reductions in incontinence episodes. However, there were more favorable impacts on quality of life measures when randomized to Botox, and the Botox patients were more likely to result in complete continence, 27 versus 13%. And lastly, that brings me to sacral neuromodulation. I know Dr. Massarotti will speak a little bit about this as well, but a quick overview is sacral neuromodulation, or InnerStim as it's commonly known, is a minimally invasive electrical stimulation device. For the bladder, it is FDA approved for refractory overactive bladder, urinary urgency frequency, fecal incontinence, and non-obstructive urinary retention. The mechanism is not well known, but it's believed to be a reflex inhibition of the detrusor contraction by the activation of afferent fibers, either the activation of the hypogastric nerve, the direct inhibition of the pelvic nerve within the sacral cord, and the supraspinal inhibition of the detrusor reflex. It generally involves a two-step process. You can either do a percutaneous nerve evaluation in the office, which I generally do, or a stage 1 procedure in the operating room. The sensitivity and specificity of both are generally around the same. And the patient essentially wears an external battery for 3 to 7 days to evaluate the percentage of improvement in urgency and frequency. They maintain a bladder diary during this time. If the improvement is greater than 50%, then we would proceed to step 2. There's 2 battery options. rechargeable battery that can last up to 15 years and a non-rechargeable that lasts around 5. And now there are 2 companies, Interstim and Exonics, which are now providing these services. When it comes to the data, the INSIGHT trial is the big trial that was done in 2017, 2018. And essentially what it showed was pretty good improvement rates in both urgency and continence and urgent urinary frequency at 12 and 24 months. About greater than 80% of patients developed about a greater than 50% improvement in their symptoms. And there are other studies that have shown improvement rates around 60 to 90% and cure rates of 30 to 50%. Adverse side effects occur in about 30% of patients, and surgical reintervention really is a pretty low percentage in about 13% of patients, site pain being about 4%, loss of efficacy about 4%, and infection around 3%. So a quick bit about concomitant bowel dysfunction. There are some studies showing that your urgency and bowel dysfunction are hand in hand. So Gill in 2012 performed a study that showed 83% of patients with urinary urgency incontinence had concomitant bowel dysfunction. And at 4 months post-implant of the sacral neuromodulator, their Likert scale rating significantly improved from baseline on both symptom questionnaires, as well as another study in 2012 that showed 5 years post-implant that urgency incontinence episodes and fecal incontinence episodes were significantly reduced, and 73% of improvements in both forms of incontinence and quality of life measures. So they did compare the efficacy of Botox to neuromodulation in a multi-center trial of 364 women with refractory urgency urinary incontinence. They were randomized to either 200 units of Botox or Interstim. At 6 months, the Botox group did have greater improvement in urinary incontinence episodes. However, at 2 years, they both had similar reductions in their symptoms. And they both had similar rates of complete resolution, which is rare, but about 5% in each group. So for the patients who obviously fail third-line therapies, there's always an option of augmentation cystoplasty or urinary diversion, and for that I refer to my urology colleagues. So into further ado, I will pass the bar on to my colorectal colleague for the fecal incontinence portion of the talk. Thank you for your time.
All right, good evening, everyone. My name is Haane Massarotti. I'm a colorectal surgeon at AdventHealth Tampa and Carrollwood. I've been with the group for about 5 years now since I finished my training, and today I'm going to be talking about fecal incontinence and a focus on the surgical treatment options. I have no disclosures. Today I will discuss a little bit about the etiology of fecal incontinence, how we manage it, and what we do to fix it as surgeons. Real quickly, it is very prevalent. Most concerning is that less than 1/3 of patients who have fecal incontinence actually seek medical care. And this is believed to be multifactorial due to embarrassment, lack of awareness. Multiple individuals think it's something they have to live with. It's just part of getting older. It's part of life. Also embarrassment, which is probably the biggest factor from a provider standpoint. As providers, we often don't discuss these issues if the patient doesn't bring it up, but it is common. What is fecal incontinence? So it's often called fecal leakage, but the definition, or accidental bowel leakage, is often used interchangeably. By definition, it's the uncontrolled passage of feces or gas. So fecal leakage, like I was saying, is often used by most patients. However, it is different when we sort out the symptoms. And the difference is fecal leakage. I often ask patients, when you go to use the bathroom to urinate or void, do you have passage of stool on your underwear? Or when you go to wipe after you void, do you have stool, which is different than fecal incontinence. Fecal leakage can often be caused by something mechanical, such as a large hemorrhoid, anal fissure where stool is getting stuck, whereas gross fecal incontinence is the actual uncontrolled passage of full feces or gas. The differential is listed. In general, I rule out all medical and dietary causes such as allergies, gluten allergy, thyroid disease. Diabetes is very common and has actually been associated with fecal incontinence. So folks with uncontrolled diabetes will often have fecal leakage rather than fecal incontinence. One other thing I want to mention here is folks will tell me that they have incontinence, but when you actually sort out their symptoms, it's an overflow issue. So this is how I describe it to my patients. Imagine if you have a big boulder between two, large, basically columns of rock, and it rains and the boulder's stuck. The only thing that gets past the boulder is going to be the rain or the liquid. So actually the patient is not incontinent of fecal incontinence is the diagnosis, but it's rather constipation with overflow fecal incontinence. And then last but not least, obstructing colorectal cancer, which secondary to, kind of as I described, will cause leakage of stool. Risk factors are listed. As mentioned by Dr. Prieto, urinary incontinence is more of an association and usually related to the underlying pelvic floor disorder or common etiologic factor. When patients have fecal incontinence and have IBD, which is Crohn's or ulcerative colitis, or radiation proctitis, the treatment pathways completely different. So it's important to sort out that history. How do we evaluate fecal incontinence? There's multiple scores. The score that is most commonly used is the Wexner fecal incontinence score. I have this saved into my Athena as a basically pretty easy way to document. And I ask patients, the following questions. It's a good score. It's not perfect, in terms of the lifestyle alteration. You can have, the relatively young patient who's very active, who has just a little bit of leakage, but it significantly alters their lifestyle versus maybe patients that are home, wheelchair bound, who are sort of used to just being home and have fecal incontinence and it doesn't bother them. So those sort of issues are definitely important to sort out. The other scores include FEESI or the fecal incontinence quality of life score, but most commonly it's the Wexner fecal incontinence score that we use. We evaluate fecal incontinence multiple ways. The most important is a finger exam. In the time of COVID, it's been challenging with virtual visits, but in general, anal ultrasound has sort of fallen off of we do it mostly for academic purposes to evaluate for a sphincter defect, but as you'll see with the treatment, it's not quite relevant. Manometry, pudendal nerve testing, also more academic, but can test the status of the nerve, and then defecography, which there's two types. There's MRI and there's X-ray. In general, we like the MRI defecography because it gives us a 3D view and it can also evaluate for multi-organ dysfunction. Defecography is more physiologic when the patient does the test because they're upright and there is actually a toilet in an X-ray. I remember in my training at a smaller hospital, my attending would bring her toilet. I had to bring a toilet to X-ray at a smaller community hospital just to ensure that we got adequate evaluation, but it gives us a lot of information. With the most important, initially, we start with medications and lifestyle. We start with the bowel diary. That way we can get an objective idea of how severe the fecal incontinence is. Dietary modifications. Psyllium husk or Metamucil is the most important part of our management. And sometimes we do use other medications. Patients we can even try scheduled enemas where before they leave the house, they can give themselves an enema. The next line of treatment is biofeedback. I see there's physical therapists on here, so we definitely appreciate your work. And this has been definitely the most studied with fecal incontinence. Fecal biofeedback is has multiple tools in their toolbox to help rehab the pelvic floor. While there has been studies that show improvement, only less than half of patients who we prescribe physical therapy actually make it to the appointment, unfortunately. Surgical options, there's multiple categories. I'm not going to go through a ton in all of them, but in general, you repair it, make it better, replace it, stimulate it, or completely divert the stool. Overlapping sphincteroplasty has been the operation for many years. It's been done in women with 4th-degree tears, large vaginal deliveries, identified sphincter defects. Patients do not necessarily need a diverting stoma, but this is definitely the most studied technique. In the short term, the success is great. There's been data for many years that shows this, up to 93%. However, in the long term, at 5 years, as you can see, the success slowly decreases. So on the bottom, you have the months of the study and percentage of good outcome is a patient identified, success rate basically. But over years, there has been failure. This is the overlapping sphincteroplasty. With the way that we augment it was injectables. Celesta is the brand name. It's a hyaluronic acid that's injected. The benefit is done right in the office with very little morbidity, with very little discomfort. Radiofrequency, it's also known as SECA. The idea is that you apply radiofrequency, which causes collagen deposition, subsequent scarring, and then patients can improve the sensation. Here's the results for injectables and the list of the different injectables. As you can see, the studies are, the numbers aren't great for the studies that are out there. And the follow-up is, there's really no long-term data out there on injectables. And the reason for that is the arrival of SNS or InterStim on the market. I do still do Celesta, just to be completely transparent. I do have a hard time getting insurance approval, working with the company to get it to my office. But, in an academic setting, it may be a little easier. More results on injectables. So a little bit more radiofrequency I talked about a little bit. Once again, applying radiofrequency energy to the anus under anesthesia. This does take a long time for the results to occur. It is one company that provides it. And I have done this in my training. I've not done it in practice due to availability of better options. The results, once again, the follow-up is not great. When looking at the Wexner score, these patients do have an increased quality of life and a decrease in the Wexner score. So decrease in the score is correlated with improvement. Dynamic gracilloplasty is another form of replacement where we essentially take a muscle, we use the gracilis, we literally replace the muscle in vivo and then stimulate the muscle to work. It's the problem with this is it's technically demanding, requires special training. Here are the outcomes, which, as you can see on the right, the success rate is pretty high. Artificial bowel sphincter, I've only taken these out in my era. It's basically requires manual dexterity, and basically there's a balloon placed around the anal muscle. There's a handheld pump that's placed in the vulva, and the patient, so it's obviously most likely in a woman, and the patient will basically release the balloon when they want to poop, so deflating the balloon when they're passing their stool and inflating it when they don't want to pass it. These are the complications are high. As I said, I've only taken these out. Magnetic anal sphincter, there was some momentum in the studies, also wrought with complications and hasn't shown to have great outcomes. Like I talked about, all these replacement mechanisms do have high rates of adverse outcomes. Sacral nerve stimulator is by far the best treatment we have. It's a 2-stage procedure that can either be done the first stage in the office, the second stage in the operating room, or both stages in the operating room. I was trained and I prefer the 2-stage approach where under X-ray guidance or fluoroscopic guidance, we put a tine lead into S3 with the patient not under general anesthesia without muscle relaxation, so we can test also for not only the somatic, but so we can test for all pathways to make sure that we're in the right sacral nerve foramina. The mechanism is largely unknown, actually. What we do know is it doesn't necessarily make your sphincter stronger, but it likely works through sensory pathways where patients can detect their stool and therefore give them time to go to the bathroom or actually make it to the toilet. There's also been studies that show it affects colonic transit, so it causes retrograde colonic sequences, which decrease the passage of stool. Lots of data out there. Most of these are this is the short-term data, which is great. As you can see, the p-values are are all significant for improvement. Once again, as the score goes down, the outcome improves. Quality of life from all standpoints have been shown to improve with the sacral neurostimulation. Just to back up, Dr. Prieto didn't mention this. Medtronic made InnerStim, and they were the only company on the market for many years. And Exonic is the newer but updated version. But both, I use both. For 5-year follow-up for sacral nerve stimulator, there's been great long-term data, and basically using the multiple fecal incontinence scores. As you can see in this, I know it's confusing, but in this graph, the higher the score, the higher the quality of life, and up to 96 months, patients do have a persistent improved quality of life. Adverse events are rare, and when they do happen, there, as you can see, there's a lot of zeros there. Number of serious events, percentage of patients, they're often minor, such as site pain, paresthesias. I do tell patients with quotes that one of the adverse events is that it doesn't work, and if that works, you take it out, and it's a minor outpatient procedure. So lack of efficacy is something that I talk to them about. One thing I wanted to talk about here, in terms of the diarrhea, what's interesting, and I think this is definitely one area I think has an area for research is, so when you implant a device, obviously there's a risk of infection. There's no great data on how long to give antibiotics for an implantable device. We know antibiotics cause diarrhea. So when we look at their Wexner fecal incontinence scores, it's hard to sort out, is there diarrhea from the antibiotics or is it from lack of efficacy? And this is something that has definitely something needs to be evaluated. The long-term data is great for SNS, or sacral neurostimulation. Once again, Tracy Hall, she's out of Cleveland Clinic. She's definitely one of the gurus of fecal incontinence and pelvic floor disorders. Show that there are 120 patients who we define success as over 50% improvement in incontinence episodes, improve in all categories, up to 8 years even. Obviously, it's only one patient. So what I tell patients is after 5 years, 88% of patients still have efficacy versus the overlapping sphincteroplasty where over time the efficacy decreases. Once again, long-term data increase in scores, increase quality of life. So, once again, this is another study that showed the efficacy still holds up even when patients have a sphincter defect, pudendal neuropathy, or a prior sphincter repair. So if a patient, even in the absence of a sphincter, this treatment works, which is sort of crazy to think about that. The sphincter, there's actually a block of sphincter that isn't healthy, yet patients are still able to maintain control. There's been data out there on the indications for SNS with other comorbidities, including after radiation, after a rectal resection. So this is a whole other talk, but low anterior resection syndrome is a syndrome that demonstrates fecal incontinence urgency and frequency. There's been data to support the SNS even works with that, spinal cord injury, and other pelvic floor injuries. Last but not least, the last resort is a diverting ostomy, which we do. These are mostly older patients who are debilitated in a nursing home or have a caregiver. It's actually easier for a caregiver to care for a stoma than a stoma through the anus, which is basically what fecal incontinence is. And that's all I got. Thank you for your time. Any questions?
Hi, Dr. Massarotti. I'm actually one of the pelvic therapists. I just joined the team a couple weeks ago. I actually was wondering if y'all are using the Eclipse device. I learned about it about a year and a half ago, maybe 2 years ago, and I don't know if it's still in play, something I should be continuing to recommend to patients or anything like that.
Is that the device that's inserted transvaginally? And maybe Dr. Prieto, you can comment. Yeah, she's shaking her head. I've been aware of it. I do save this because of the good long-term data on SNS. That is my first line therapy. But patients who don't want surgery, patients who aren't healthy enough for surgery, I do refer them to get this device. I don't personally implant them, but it is a great option for patients with fecal incontinence.
Dr. Prieto, is that something that you're doing, or is that still, I know it was in trials and stuff like that and doing a lot of research?
Yeah, it's currently still in research, and only academic institutions have access to it. So I know that USF was trialing the device, and then unfortunately due to COVID, I think some of the trial had to be halted. I'm not sure where the status is currently. But it's definitely a good option for patients. It's just not on the general market currently.
Okay, thank you.
All right, well, have a good night.
Thank you, everyone. Have a great night.
Thank you.